go for a tea break. One is that Dr. Madhurika Banerjee has kindly agreed to give one more lecture today evening. So we have the 3 to 4:30 session, then maybe 5 to 6. We are all Thank you for agreeing there. Second is that another suggestion by listening to you. Can we start a Google document where you could all contribute what you think to be a serious reason? If you are coming across papers, books, which we can start a Google document where you can continue. That could be a tangible outcome of this gathering, that we will all be with some amount of good readings which each of us find or who have written. Right. So we'll talk to Manganam and we'll set up a digital way of doing it.
But before that, I think there's one interesting solution came from areas is that we can think about publication afterwards. But my suggestion, instead of we think about individual papers and all that, can we come out with a collective some publication afterwards? Like in the one thing that maybe in the model of Wikipedia or something where we contribute, we write, and then some of us edit. And finally, that people who are interested in the areas who come after this, there will be some document which came out of this. So that we can preserve both our focus and also diversity of opinion. So please do think about how can we put this in practice. But we have an offer that something like this, the university and the chair can take it to some publication. And also please keep in mind the reading things which. So what I thought I wanted to say is that what led us to this and what maybe some of the other sessions will look into it. And the starting point was, as we said in the very beginning, that like I teach in IIT, kind of supposed to be a cream technology institutions. And we have very full-fledged humanities and social sciences department in most of the IITs. And it's okay. Yeah. Like priests, we teachers are also used to standing and giving our sermons. So, and some of the humanities and social sciences, and they are very diverse. Like it's not like some relevant. We have from linguistics to cultural studies to cognitive studies to economics, psychology, sociology, everything. And the humanities departments are bigger than even many of the engineering departments. And but we don't find something like that in medical institutions. Maybe there are some courses in, say, sociology and psychology. Okay? So then why are we disturbed by this? Am I trying to create job opportunities for humanities people in medical sciences? So that's where some of us, during our conversations, we have felt that there are doctors who have very important engagement with some of the issues which these disciplines handle. And these disciplines have now started working on medical sciences. Now, medical humanities is a established uh, area, and where medical knowledge important for pursuing humanities. And we are looking for some way of formal training in fact, I've been the committee of couple of very important medical humanities thesis now in well-known universities. But in the thesis committee, there was not even a single doctor. We people in humanities judged whether that thesis is adequate or not. But we have to maybe, is it possible for us to have a common thing to evolve? But there is a lot of work now happening in medical humanities. And in medical social sciences, even though they don't call it, there's a lot of work has happen. So the idea is, can we think about talking about this? That's why we don't want to make it into a kind of lecture and learning mechanism, so that, and also that's why we thought about even a patient interaction, because can we think about, you know, people who are cognitively concerned about a patient? Can we evolve vocabulary to talk about it from different perspectives? Uh, Now, even though the IITs have a humanities thing, but many of us who are in the department are deeply disappointed by that thing, right? We think that that model is crumbling, and this is why how uh, this humanities department entered IIT. See, many of the engineering colleges, even in Kerala University, has economics and English, right? They think that these are relevant for the engineering students, so they all have economics and English. And now the IITs have complete humanities, like a small university. Now it came from a Nehruvian vision that engineering and science education doesn't address many aspects of human life, right? They wanted to make a holistic citizen of India. Now, holistic citizen of India should also know that there is a society there, they have values, they communicate, there is a literary tradition. So give him a little bit of these things so that he is a complete person. But there is no effort is made to see whether what he is doing has a cognitive relationship. Should a person who is doing engineering should learn anything from art? Right? And we know that in 300 years ago, in the European universities, music and mathematics were taught as part of the same trivium quadrivium thing. You studied one, you studied another thing. In Kerala, we had poets in the 17th, 18th centuries who are also mathematicians. They are also contributing towards percussion, developing percussion orchestra. They are also composing extremely metered rhythm poetry, and also they are writing philosophy. Right? You have knowing one demands knowing the other things. You will find in in medieval times, in fact, people get scandalized when we do, for example, a philosopher like Descartes and Shakespeare were contemporaries. Both of them were thinking about what are the consequences of doubting, asking about foundations about this. Then you have Renaissance painting, which is using Descartes' analytical geometry vision. So everybody is competent in other fields, right? Is there a way we can now think about the Nehruvian model in IITs? Never thought that engineering, science, education, and anything to do with this, but you would need to a context. That's a lot of word which is used. This we exist in social context. Some people say some context we need to know those contexts, like economic context, social context. You have to start your industry in the society, and you have to talk well, so you should know good English, right? And the other thing was that look, you should anyway know to become a complete person. And in my opinion, this is total, because you know that the students are forced to do this. They do it as kind of entertainment. They're light courses. They are not as taxing as the engineering courses. And people who are serious realize that humanities is not doing this work. For example, those who are interested in economics and society and concerned about the actual pursuit of engineering, they said what we need is a management studies, not humanities. Right? So all IITs have now started management studies departments. And for example, ethics. Now, in fact, when we started this conversation with people in the medical profession, one discipline where they were all very welcoming was ethics. They said, look, we have a lot of ethical issues about medical professions. We have to make the doctors more humane. So we need to have, I think that there is immediately accessible, there is some ethical thing you teach them, they will all become good. And in engineering institutions also, this belief was there that if you give some ethical course, they will all become. But many of us are teaching ethical courses that has not made us good human being, nor our students human beings. So IITs have all started now value education centers. These are very religiously, part of the um, Indian Hindu traditions. Swamis are teaching in some of them. They think that look, they are all good human beings. They will make them into good human beings, right? So the fascination with humanities is not very innocent, and I think that we should think about: is this the way which we are thinking about getting human? That is to make doctors more ethical, compassionate, make them rooted in the social context, right? Or we want to think about, I think morning somebody mentioned this, I think you mentioned it, whether they're cognitively, whether they should be linked to the social sciences. And now the thing is, there is an interesting experiment was done in Hyderabad in Hyderabad, the triple IIT, the Indian International Institute of, I think, Technology. They had a department called Department of Exact Humanities. Hmm. They said, look, we don't want this humanities to get the social, historical context and all that. But the engineering is like, computer science today cannot be done without thinking about development of complex forms in modern painting, right? You can't do, for example, Indian constitution, if you really want to know the inner structure of that, you can't do that unless you study the structure, complication structure in modern software programming. So they made science, the uh, computer science, mathematics, and art and music, etc., together, right? But this comes out of the vision of one person, right? Navjoti Singh, he died very young. And then we realized that none of his colleagues understood what they were doing, right? And the whole thing will, I think it will collapse. Right. So that's why it's very important to generate a common vision if you really want to do this. Right. So IITs have an European model. It has finally collapsed into, you have management studies, value education. Now you have policy schools. They said, look, these are the place where you really want to study the social background. And humanities is there. And you know that many of the new engineer IITs which are coming, they are not interested in humanities department. And ISOs have almost said we don't want humanities education. So that's why we need to have a general theory, and also this peculiar felt feeling that this medical education has become made doctors very inhuman. And that also I find, though rhetorically it is interesting. I think, see, we go to the doctor when we are really sick. I don't remember ever getting cured and going back to him just to say thank you. We never do that. We just celebrate them as this miracle people, and never go. And this is, they are all doing it without even getting a thank you, from you. And I remember the other way around. I remember when my mother was admitted in a so-called very profit-making private institution in Kerala. And toward the end of that, me and my sister took a decision not to put her through uh, any of the life-saving thing. We took her home, and she wanted to die at home listening to some old Malayalam songs and all that. So after she died, the team of doctors sent us a WhatsApp message by thanking and congratulating us for taking that decision. He said, look, many people don't take this decision, and our team is extremely with you. For instead of they thank the patient. So it's very difficult for many of us to just start this conversation saying that doctors are, immoral, and some humanities have to be, introduced into this. So this whole idea that today we are talking about, we think that first of all, the patients come from social context. We need to know the social context. Another one is you have to humanize. And then the other thing is that now we need to develop linguistic skills to understand our patients, right? They will articulate their uh, intimate experiences of suffering, and they will also articulate um, narrative wise. So we need to now pick up literary techniques of narratives, conversation example, in order to understand, these people. So are we going to check? And these are also very pedagogy oriented in things that what it's not like we are talking about medical profession. We think that humanity should for pedagogical training. After that, they should go and practice their own practice. Is this the kind of way we want to uh, think about it? But on the other hand, we also find in literature department, sociology department, excellent work is being today done on medical professionals. So recently, I examined a thesis by Sumawa Maiti in Delhi University, where what he tried to do was that he looked into the 18th, 19th century literary narrative, and he found out that, for example, if you take a poet like Coleridge was, this is also the time of scurvy being discovered as a major sailor's illness there, and that's also the time the sailors are getting scurvy, hence they are very nostalgic, right? And nostalgia is a major category for romanticist thinking. And Coleridge and many of the poets are into serious exploratory medicine. Right? They are writing poetry on scurvy, they are reading all the medical treatises, they are themselves getting open to colonialism, to various other cultures, they are exploring various ways of cure, etc. There's a serious medical inquiry connecting scurvy and nostalgia among the British poets. So, how do you read them? Now, is this reading in any way significant to doctors? Or it's like psychological, we can separate between what is caused by vitamin C and what is caused by nostalgia. But there is something about visibility of a new disease and various other things becoming part of it. So now there is a lot of work now on yellow fever, smallpox. Now we talked about cancer here. I think two of you are working on cancer, that the way cholera became visible. And even after this pandemic, one of the greatest work which came out was often Pamuk's The Night of the Plague. Now, does this make any sense to a doctor today that reading this book, cognitive in his treatment and his approach to, disease? Now, the another aspect, which one is a general question about what should be our approach, right? Second is a lot of debate is today taking about the scientificity of medicine, right? And that's also we should think about how much of it is we should open it to where we can have a. So fortunately, we are all people who have some faith or some comfort with modern scientific medicine. I think we don't have, other than Matulika talking us about Ayurveda, we don't have a Ayurvedic or a homeo pseudo-scientific voice to talk to us. And when we listen to these discussions, I think this will be taken up. We think that the question of science is a question of method. Right? It's a peculiar thing. So the physical sciences are making great, progress because they have something called method. Now, this is a peculiar, you will see that, there's a course called research method, which you find only in social science and humanities departments. I don't know whether you've ever seen a research method course in physics departments. They don't do it. Because we in social sciences also think that these guys have made it big because a method, if you learn that method, either we copy that method or we have another alternative to it, we will. But what we need is method, right? So how far is this method? So method idea is that what we all want is truth. Truth is kind of destination. We need to have a way, map to reach there. So method, like odors, the word is, there is a method. In other words, our destination and where we want to reach there are different. But one thing which many of us have learned as a scientist is that these are not really separate, right? Where we want to go and the way of going there, they are the same. Truth is not something which will come till the end. And science is a very interesting practice because 95 or large number of the things which are held to be true will turn out to be false tomorrow. Still, we can indulge in that practice with great confidence. But that's because something called we have a grip on method, right? Is something which is now the thing is how much of it should be to a practicing doctor. We should open this very idea of method itself to question. And you know that in physics and all became a science when somebody like Galileo coming and declaring that uh, the world nature is written in the language of mathematics, right? And is this did medicine become a science by any such declaration? I think medicine is something by which you find the least amount of formalization, right? And medicine claimed to be a science because it is evidence based. In my mind, it's a strange thing that every science should be made based on evidence. How can there be a science which says it is evidence based, right? It's a very tautological thing to say that some science is based on, then they think that other sciences are based on something else. Basically, it's also saying that, look, we only have evidence, we don't have any. Is it they are saying that we don't have any theory? We don't have any formalization. We only have evidence. And that's not a bad thing to have, right? In the age of big data and sophisticated software techniques, we could perhaps have a science without, because even physics, there are people are rethinking now, should we reject physical theories and we can really stick to data, right? And this is where maybe a lot of discussion from philosophical because you will be strange, doctors will be strange to know that there are a bunch of guys called philosophers who never believed in basing anything on experience. In the sense, for example, if I say the general claim that water boils at 100 degrees centigrade, right? Because what is that? I have boiled water at several times, say 10 times I have boiled it water at Sandy. I can say that now general claim, right? It has worked for 10 times, 100 times. I will say water boils at 100 centigrade. But philosophers have refused to accept it. They said, look, if you boil water at 100 degrees centigrade, all that you 10 times, all that you can say is that water boils at 100 centigrade in the last 10 times. You have no business to extend it to the 11th time. Right? And if you want to extend it, it cannot be coming from experience. It must be coming from something else. Right? So, in fact, when we talk to someone who says that the science is a method and method is based on evidence, we need to know that their engagement where that itself is basically challenged. And that's not way to give up. But as I said, look, there is scope for building a science on evidence base, but it has to somewhere meet this criticism. And I don't know whether that would be that's one way in which I would think that maybe that's what this we'll get it in when we engage with Naveen and Mathulika, this question about what is this evidence? How do we think about evidence? When does something become an evidence for, right? And many people think that the evidence is always mediated by theory, right? You don't have any pure evidence given to you. You need to see what is evidence for a knowledge claim. Suppose if I have a claim that this is a black book and I have evidence of experience of this black book. So this experience should touch me so that it meets my expectation that it is the expectation is the black book, right? So I should be the experience should justify my claim, right? In other words, the experience should be familiar to me with what I am going to talk, what my demands from the world are, right? So that's the only way. In that sense, there are no pure experience. The experience have a value only if, in some sense, that experience already knows my language, right? It is familiar to me. There's nothing like going into the world and let me catch some experience business. That's why in experience, in modern science, we do experience in controlled, extremely controlled uh, experience. Now, how much of it is applicable in the idea of what a randomized controlled trial, right? In fact, the idea there is the control is to avoid randomization, right? Physicist starting point is that the world is total mess, right? And we can put some control on it so that a physicist is not worried about whether angel will come and destroy or ghost will come to the lab and destroy his results. It's not because he has any proof that there are no ghosts, right? But there are certain ways in which you can ensure that the angel will not speak to me. Angel can speak to the God and sing the glory, where I have no commitment. But the angel cannot speak because I am coded it in a language so that it will, even the angel will respond in my term, on my terms. Right? That confidence is there. Now, how do we understand this medical profession which says, I want to go to the world without a control which ensures randomness? And that's a very radical claim which it is, making. Maybe these are some of the issues which we could take it up because now what we hear is medical, what we are engaging with is an evidence-based medicine, right? And some sense, not to reject it, but we should be able to see the strangeness of that claim. And they are saying that evidence, only one type of evidence base is accepted, that is randomized control, right? Now, what is this randomized control? So then, if it is purely a randomized control, then what you are getting is a correlation, right? Now, another thing about knowledge is that we get causality. Right? That something is causing something. When you do a randomized control, Kadal, what you are doing is something is correlated to something. Right? Now, what is it that a science should give us? As well, should is correlation are they necessary for causality? Are they sufficient for causality? The medical sciences today saying that that is necessary and sufficient for making causal claim. This thing causes this disease. Please go ahead.
This is very limited by. I really do not think that that's what it says in research. We never say that correlation says that it is causal. We always say that this is something we learn that association, what we say, like, or correlation or association, does not imply causation as what we learn. Just because something is correlated, or when something increases, other increases, or something increases, other decreases, that doesn't actually mean that it is causal. It just means that okay, we saw some kind of a relationship between them. And um, this is also kind of, yeah, when you think in the philosophical theoretical terms, maybe this is again that. But what we study something is Hill's criteria of causation. So, along with association, there has to be some other criteria. But this is something that Hill developed long back. So, maybe there is something that added on to that also. And one of that Hill's criteria of causation is experiments. Like that. Then other there is temporality, there is biological possibility, whether it is possible in the current knowledge. Depending on the current knowledge, is it possible? So there are several other criteria that has to be added to the association to say that this is causation. So from my understanding, we never say that it is a causal, but we do say causal association based on, like, for example, there is TB bacilli and you get tuberculosis. That is a causal association because you can get TB only if there is a bacteria, like that. So that you can call as a causal association. But the rest of them you only call association. And what we are assessing is that association statistically significant? And for that statistical assessment, we have some assumptions definitely. But that is what I understand. Like, I don't think medical evidence, it never says that, and we always say in probability terms. We never say anything in the certainty terms. It's always probability, and it is a limitation definitely. And from what you said, like, yeah, we have to believe in something. So then we have to apply to a large number of people. So we have to believe somewhere. So that is my understanding of that.
I think all science have evidence, but with medicine, we are learning a subject and we are not the authority. And of course, many people practice in their own view, but there should be something uniting. Because a new doctor may need some guiding light how she can treat a particular disease. So we need to have an evidence. Maybe a professor A might have been taught in one way and he will be teaching his knowledge. Another B will be teaching in another knowledge. But the evidence by having a controlled trial, we are saying, though it looks very logical or some, see, if let us say if for pregnancy, taking bed rest will prolong pregnancy, but there is no evidence for that because pregnancy is not going to be prolonged because she is going to lie strictly on the bed. So we can freely or strongly support that, saying you don't worry, if it is a good pregnancy it will survive even without you taking that much rest. But if that pregnancy is going to be aborted by natural cause, the same person may come to us and then we have this evidence, see this is what is there. So we need something to stand on, something to support us, that is given by this evidence based medicine. It is not to say that this evidence is making medicine more scientific. We have so many advices or truths, but this evidence is helping us to sift through all these truths and find out which one is grade 1, means more scientifically backed, and which is second grade or B, where it is an experience of the individual doctor. I might have noticed something which helps the patient, but that doesn't make it is an evidence. And this regarding the randomized control trial, of course, we cannot do an experiment like a physicist in a lab. Each individual, even twins, will be different. Same time, their genetic makeup may be different. So this control, what we can do is what best things we can control, we are controlling it with the full knowledge that we cannot control everything. And we need something to hold so that we can guide. And this is the best way, rather than being philosophical and each one taking their own advice. We should have something. If there is a train, it has some logic how it is running. Some engine, some energy, some volt, which has to be there. Same thing, we need to have some structure in our brain to help others. That is, I think these two are helping us with that. Thank you.
Quality of evidence, we know the hierarchies of RCT and empirical data, where we stand. But at the same time, as a practicing physician, I always do not solely depend upon evidence as such, because all this evidence, I know these are guidelines and people have done in that ancestry, this ancestry, in that lab, this lab. Everything is so robust in literature and every paper. But at the same time, when it comes to your patients, there are a lot of confounding variables which are there. So I use my acumen of experience or whatever, clinical instinct to make my decisions. And this is how I think all the doctors do at the best interest of their patients. So that is where we stand. So this lines between, and when we talk about alternative, like what you told, pseudo-scientific things, so-called pseudo-scientific things, and in the modern, as a person who has studied modern medicine, the biggest argument is that they are not evidence-based. Neither is Ayurveda, neither is homeopathy. So when you look for this, all this repeatability, all this measures of evidence has come from a modern medicine point of view. If you use the same balances to look into the traditional systems, you cannot find any evidence. But I have a very strong association, I should say, with homeopathy. And then I know the diseases, they are treating diseases and the disease is cured. So that is what you ultimately want. So how, what, and we may not be able to explain, but I think all the, from a scientific perspective, however evidence-based you are, you should have a lot of skeptic in you to make that an entire playground is there waiting to be explored. So that kind of humility is sometimes missing. There are a lot of other factors also, but ultimately we believe that association is not causation. That is what we are taught. We don't believe in that also.
Start with, maybe we go back to that intervention to start with and then we come back to evidence. See, I also sometimes do this sort of experiment with my students, and I sit on the 4th or 5th floor in the building, and by the middle of the 2nd or 3rd week, students are getting very irritated with me. So then I end up with this, usually 8 o'clock in the morning, so it's even more, you know. So I said, if we have an experiment when you guys get so irritated with me and you want to throw me out, right? Throw me out of the window, etc. How do you know for sure that you go down, right? I could just fly off. That sort of a. So this is typically called the N+1 problem, sort of, where you are trying to understand the knowledge base of a knowledge claim. Yeah? What is the basis with which you say something which you claim as you know, episteme is what some people would call it. So what's the basis for it? So one way to then say is that I'll fall down, I mean maybe die or breaks many of my bones, is because there were many people who have done it famously from that Tower of Pisa, no? So you throw it down and so on. The other way is, but there are scientific theories about it. There is theory of gravity. That's where then things start getting heated up. So how do you know that theory is true or not? You then say that there is an experimental protocol, there's a methodology through which this has happened. And then the question which goes back is that you have a relationship with the future claim. That this has happened till now, and because this has happened till now, it will happen again. Once you enter that field, you end up with some uncertainty if you are a little agnostic about it. If you've already signed up for that scientific claim, then it's okay. But here you are asking, under what basis do you know that this scientific is going to be predictably true? And all the time, you can only say, I have done it 200 times, I've killed 200 of my teachers. See, so that's the only, you don't know the 201st teacher will go down or not. So in a thought experiment, there is definitely a problem there. We can always sort of brush it away by saying that this is just, as our students say, hookah, it's a hot air. So that's one way to say that, we believe in the efficacy of the scientific knowledge claim. But it goes back to belief then, that's fine. But we are believing it. We cannot make a scientific claim that this is going to happen again. That's the tension here. We know at some level that no, it's going to happen, right? Because we are trained and we are encultured and so on. So that's the difficulty here. Sort of, if we have to really look at the knowledge claim of that particular claim, which is being called as science. It's a typical old problem. So it's not that leads us back to the question of authority. Because we are talking about the question of authority. In my next session, I originally only wanted to talk about biomedical research. But I also want to do that space between the patient and the practitioner. Because a lot of time what someone like Polanyi, a 1950s philosopher, who would talk about tacit knowledge. A lot of scientific expertise, he would think, is also not just about developed theories and you're just mouthing it out. You're using it in various ways where there are some stuff which you read, some that you have intuition, some that is also in the air. You're catching it. Right? So there are multiple things which should possibly happen, as she says, in a space where you're meeting a so-called patient. So that expertise, how do you characterize it as purely scientific, becomes difficult. And this again is at least a 500-year problem. If you think about causation, in terms of, there are 5, as old as Aristotle, he gets into 5 kinds of causation. And he says one of the causation is the probabilistic causation. That's where we end up. But why I went to Israel and have to come back is by 1500s there is the Pajwa school, the Renaissance school, which gives a lot of ideological and backbone for the Western science yet to come at that moment. Yeah, so the claim that okay. Let me just talk about one particular person, somebody called Zuarelli. So essentially he's a classical neo-Aristotelian who would make a claim which is not really controversial at that time, that medicine is not science. That's his claim. Medicine is not science. And that we want to talk about, in this case, causation in medicine. That's different from causation in physics. Something which we can look at it later. But why I'm trying to talk about him is this. When you have authority to speak, like you have to say it with such, I remember you say, you need some authority, right? In the morning session, if I say maybe, then the patient might not be. So then the question which we end up with is what's the authority of the expert knowledge in that particular space? It's partly this claims of causation, but there's something else also which is happening. So then I think what both of us in some ways are trying to do is that by the 80s and early 90s, you have the RCT phenomenon coming up. It's coming up from a different field altogether, but big time work into, so that the subjectivity of the expert doctor in this is taken away as much as possible by saying that there is something which is evident coming from a lab, not a lab in the classical sense, but coming from a particular space of RCT. Everything is controlled. And then we have this, and then what is evidence would then end up being about evidence is that which makes causality evident. No? That a causal relationship which you as an expert sitting across the table from a patient to say that this, eating this would cause you to have this or not to have this. Right? So there is a causal relationship between your treatment and what happens in the future. And that's how do you make that claim of a causal relationship? Through something called evidence, and so on. I think we deviated too long, but I think it's already, give it back to you.
And I'm so excited that the discussion is taking this turn. Just to say that, two things we need to, and what I have to say, I'm not a philosopher. For me, the political, economic, and the sociological dimensions are more important, but I'm trying to put them in a complementary way to what the philosophers are saying, which is that, as doctors, your subjectivity, when you're saying that, I take a call, I judge, and so on, your subjectivity is very important. And I'm sure you know it, and I can tell you as a patient that is deeply respected. The point where this whole causality and evidence becomes something that is apart from your subjectivity is when you use the medicine. What medicine are you giving to your patient? That is a medicine that you are not making. It is coming to you from a completely different frame, and we'll talk about it later. But that frame rests on this whole generation of evidence and generation of a causality, which binds you in a certain way. Right? So when you are making a judgment, okay, this patient needs this. But your tools of your assessment are one, but the material tools that you have of medication, whether it's an injection or it's tablets or whatever it is that you have, those are things that come to you externally. And they come to you from a different frame, they come to you from a different system of production. And you don't actually have any control over that. Right? So You need, what you are doing most of the time is you're balancing your subjective judgment with the kind of medicines that you are, let me put it sharply, constrained by. Because the more nuanced a doctor is in terms of approaching what the patient, and if they are listening to their patient, which so many of you, you are here because you are those kinds of doctors, you listen to your patient, then you know that it's what you are giving them may not necessarily exactly match your own subjective assessment based on what the patient is telling you. So you are actually doing a difficult balancing act between your subjective experience and the objective materiality of your medicine. So, and I know this for a fact. I mean, as a patient, I'm saying. So there is this viral gastroenteritis that is going around in Delhi badly. It's affecting all kinds of people. And the doctors in my family, the younger doctors in my family, are saying just stick with homemade ORS of different kinds. Don't use too much sugar, use this, drink charge, because we too have a lot of buttermilk in the north. So just keep drinking a lot of buttermilk, make different versions of ORS. And the older generation doctors are saying 1 round of antibiotics and you'll be fine. How can you be fine with antibiotics in a viral gastroenteritis? So this is a kind of causal kind of problem. And the doctors, the younger doctors who are saying, do not take any medication. I know that patients are a little bit wary and they're wondering what's going on here. How can a doctor tell you not to have any medicine? Because that's our association. Whereas this doctor is actually relating to, he is listening to what you're saying. And he's relating to your body as a very different system, as one which does not necessarily need to equate a system of disbalance, unrest, discomfort, illness equal to one particular kind of medication or even a combination of medication. That's one thing. The other thing is that as doctors, what I said earlier, you do not have actually control over that material with which you're supposed to work. And that is something, again, that a lot of doctors have tried to intervene with pharmaceutical companies and so on. But pharmaceuticals are a whole realm of materiality, which is linked to so many other issues of causality, of efficiency. It also goes into efficiency, into economy. So, therefore, there can be no given templates of evidence and a judgment and when how you recover from illness. We are not even talking about other forms of being well, preventive, etc. We're not talking about those at all. Just illness for illness. That's a realm that we don't talk about at all, which I think, and doctors don't feel that they have the capacity. You study pharmacology, but pharmacology is not the pharmaceutical industry. It's two different things. So these are things that need to be tied in because they are tied in, they need to be tied in analysis because they are tied in your everyday practice, in your everyday life. They're completely bound. So I just thought I would flag that one particular aspect.
Yeah, so let me try. I said I'm not a much of a doctor these days, but let me try to bring some hardcore medicine into the discourse. So if we have, there is a condition that we call neuropathic pain. So it's a pain that is because there's something wrong with some of our nerves, which could be because of long-standing disease like diabetes mellitus, or the nerve is getting compressed by a disc that's out of place or some other reason, or it could be because nerves and blood vessels are deeply intertwined, long-standing vascular, uh, the, the biomedical jargon there, vascular disease can also manifest as neuropathy. So when we look at the evidence there, we have many medicines which could be useful for diabetic or peripheral neuropathy. Some of the cheaper medicines like amitriptyline, and then you have costlier medicines like pregabalin, gabapentin, etc. So if you look at the RCT evidence, the pregabalin, gabapentin is much more efficacious, much safer than amitriptyline, which has more side effects. But then when we look at a poor patient, you prescribe amitriptyline or pregabalin. They may buy that for a week, maximum a month, and that's it. So if it's a lady who has, say, poultry and she is a diabetic, long-standing diabetic, and the pain is affecting her livelihood, if we write a costly medicine, it doesn't solve her livelihood issue. But if we write amitriptyline, she can kind of take it for 10 years. We can arrive at a level of pain that she can tolerate and continue to pursue her livelihood. So then I just wanted to share that example out here. And just to support what Madam was saying here, today it's, globally health systems are moving in the direction of insurance based, so medical decisions are political decisions. What is going to be funded is a political decision and not a decision by a doctor. The armamentarium of the objective materials I have is determined by a political decision made at maybe at Delhi. What Sri Chitra offers to stroke patients is determined by decisions made at Delhi. So where you choose to put your money, I think looks into the evidence of this form, but also is determined by many other things, which some people say is more of a political decision than a evidence. Last thing I want to say for now is that we've moved much beyond Hill's criteria. We have two schools of causal reasoning. One, we have the directed acyclic graphs, the DAGs, and complex causal pathways, and how finally why something is coming up. And the other school in health sciences is, Alex Broadbent, Nancy Krieger, kind of, who kind of don't give too much importance to the mathematical part. They kind of are very critical of this. DAG is something which AI and big data sciences can do wonderfully. They can just scratch the web, bring out a lot of evidence, put it together, and do a causal pathway and something. But then you have the other group who are totally critical of this, and they say, everything is ecological. It depends on the context where things happen. Yeah, thank you.
I have a friend who was doing sociology in JNU. So he got admission in Oxford and he went there for his PhD. So after reaching there, after a month, he started coughing a lot and spitting blood. So he went to the the doctor there, and they immediately asked him to do TB test, and they diagnosed that you are coming from India, so you have TB. Even though the test was not positive, they started giving him medication for almost 2-3 months. And then this didn't stop. He again fell ill and he was about at the verge of actually passing away. So his parents got him to India and they went to higher tests and all, and he was diagnosed with a lung cancer. So evidence, causality, all how do we under the bias, context, subjectivity of the doctor? So how do we understand this?
One size doesn't fit all. We all understand that. And nowadays, many researchers are going on in our own context. And Madam was saying about antibiotics. Now, actually, in modern medicine, and we are having guidelines also not to start antibiotics unnecessarily. So our all our national guidelines are there, and RCOG guidelines, everything has appropriate treatment. So the old nobody just starts like that. Maybe I don't know what, but actually now everything has changed. antibiotic is not the solution. And we know about the pharmacology company, and we know the random studies itself. It has its own pitfall. It is for the Western population. So we need our own studies. All these ideas are coming up, and this good gene, good biome, everything is there in our this thing. But maybe the curriculum has to be changed, and the doctors have to learn more about it. Whatever we are means pointing fingers is about maybe 20-year-old issues. Nowadays, the issues have changed, but maybe it is not come to the ground level, but top things are happening. And I'm not an expert how to explain this, but things are going there.
So I think being in a place like India, in a third world place, of course, NHS is a very, I should say that it is a very low potent system when you compare with the Indian doctors, because they have a lot of protocols. And then people, somebody was mentioning about Dr. Paul Kalanidhi. He, being a neurologist, he was not diagnosed properly. The kind of delay in diagnosis is a big problem with, but you don't get that problem in India in spite of many these things. So what I would like to say is all what we got is treatment guidelines. So guidelines are something which can help you to help a patient. So that should be used as such. And when you talk about ORS and common ailment disease, as Madam told, it's very easy to, or in a very simplistic way of putting things, that you from the pill you come to the what root. I mean, as our ancestors did many years ago. But in this today's world, everything has a place. So when you talk about a very complex cancer care, if you are talking about a monoclonal antibody, if you're talking about rituximab, all these are very precise medicines that cannot be replaced by. That is what I personally feel. These are, however corrupted the system is, however market and state has policies to ensure that they win. Again, we rely on certain medicines because they have the effect. And if I have a cancer, if you have a cancer, you would like to, unless you want to die, you would like to be treated at the best of centers, with the best of people, with the best of products. So such things are there. So that cannot be replaced by homegrown, homemade. I think there is a hope even in the very scientific sectors, what we call cutting edge technology and all. So I think for each disease, there is a, so for some rheumatic complaints, Ayurveda may be the best. For some dermatological complaints, maybe homeopathy may be the best. Some others, modern medicine is the best. So all these things are there. So now a lot of things are on the public fora also. COVID vaccine. Everybody knows about COVID vaccine, how it is coming, pros and cons. Everybody is an epidemiologist. So such things are diluting what we actually want to aspire for.
One young person coming from India, and the first diagnosis will be always TB. But to rule out a cancer, they may have to do a biopsy. It's not an easy thing. They have to give anesthesia, they have to take a part of the lung. So easier thing is that give the medicines and see whether it will improve. And that will be the choice they have made. But we can't believe this is actually many areas are gray, so that medicine is not always true science. But we don't believe when it comes to us or our relatives. Suppose something happens, they didn't diagnose cancer immediately, then we will be angry. But at the same time, we say medicine is not a science. But that is also a part of humanity, or
I also believe that it is also for the protection of doctors, especially legal protection. It's not like we practice in a very free environment. We practice within certain rules and regulations, and also our actions are being not monitored, but you cannot make a mistake, or it may not be even a mistake. Like, for example, earlier we talked about subjective evaluation and giving something to a patient and treating patient based on that. If if for some reason that goes wrong, and then you're done for. And that is a very scary background in which uh, doctors have to practice nowadays. And that is really, really important, I think. I mean, so evidence actually, what I think is evidence, it helps us to make a decision. But at the same time, evidence also helps us to detach ourselves from that decisions also to an extent. Because it's, you can say that, see, it's evidence. It's there in the protocol. I did that. I am currently in charge of preventive clinic where we give treatment for animal bite. So that is something that is very common in Kerala. And when some cases come, especially when referred from peripheries, I know that it doesn't require an injection, but I'm forced to give it because the guidelines say there is bleeding, I should give. What if I just decide not to give and this patient missed their vaccination dose? Or maybe they didn't give me a history that was actually relevant, which they didn't tell me at that time when they presented. For example, there was a small scratch and the patient came to me with that. And I assessed it and said, no, you only need vaccination, you don't need an injection. What if that dog actually licked their mouth? Or there was some contact with the mucosa, which actually makes them receive that the additional injection. And it's not always like, and in these discussion, I think we also need to consider about health literacy and how much actually patients are able to make decisions. What knowledge is available to them to make a decision, and what knowledge is available to me to make a decision. Do I actually know about the epidemiology or the burden of rabies in the state, or how many domestic animals actually has rabies, or how much of rabies is being circulated in the community? How much data do I have to make a decision on that? So I have to blindly follow the protocol. And whether I can use my subjective, sometimes, for example, some people come far away and they get referred from hospital to hospital. It's a very sad thing. It's a very sad thing. Often animal bites are mostly from the lower, affected by affect the lower socioeconomic status people, because they are the ones who has to constantly walk on the road, whereas stray dogs are there. And it is a problem also. But at the same time, as a doctor who is practicing within the restrictions, within the legal restrictions, within the structural restrictions that my institution have, the protocol restrictions that I have, the restrictions on the decisions that I can make, the restrictions on the knowledge that is available to me to make decisions, it's very difficult to practice that way. It's not a very free field in which we do this. It's and the patient expectation is there. Patients comes and demand that, no, the other doctor tell I should have this injection. I should have this injection, and then there is going to be an altercation. I don't want to happen that to me. I don't want to be beaten up. See, everyone practices in that fearful situation, and the patient expectation, what patients expect from modern medicine, or what would we call as modern medicine, that also I think need to come into consideration in discussions.
So, yeah, as we are discussing about the evidence, no evidence is 100% perfect. So basically, based on the research, the evidence is being improved, or rather that is being changed each and every time. So based even in the clinical findings and clinical things, so all those things are being changed. All the diagnosis is being changed with the invention of more and more technologies. So we cannot say the all the people or the doctors who are passed out with the the knowledge and exposure they get, so all are 100% competent enough. So you should have at least to have a minimum competency to have the common management of common issues, and to know that, so when to refer the patient to other when they are not able to handle those situations. So these are the competency which these you should know. So these are the things I just wanted to have a comment on it.
Yeah, I will be really sad. It is not even provocative, right? See, I think one thing which I wanted to be, for example, we shouldn't see it as a criticism or one way saying that, look, evidence in modern medicine. Doctors shouldn't take it as a criticism of their practice or science at all, right? If you think that, look, somebody is criticizing and saying that is evidence, this has no justificatory standards, etc., That's not. Idea is that how much is the medical profession is willing to examine today, right? Is there anything in the question of evidence they want to open up? Now, doctors can say, no, we don't want, right? We don't want to open up. We know what is evidence is. Whatever little we are capable, we are doing it. But we want to know how effectively it can be done. For example, we want to extend our treatment to poor people. We want to extend our treatment to women. Tell us how this can be done, right? We just want to know this. This our medical profession doesn't tell us. We want to help the poor people. We want to make it into a more humane practice. Tell us about that. That's one way of doing it, right? That's a well-known path that we know how to respect. There are hundreds of textbooks. There are hundreds of now courses. But whether we can use it, get together to open us slightly more radically, right? And is there anything in the question about evidence, if in the question about its justificatory procedure, the epistemic authority, not the authority of some hospital name or something which you are, right? The epistemic authority, when you speak as a doctor, is there anything which we need to open up by input from other disciplines? But you can say that, look, we are really busy practicing doctors. We give our medicine and people get cured. You philosophers want to talk about an empty hair, that's your business. That's fine. We can all go back to our disciplinary comfortable zone. I also believe that when I have headache, a painkiller really helps. I also know that many of my students who have depression, medicine helped, right? But even still, we want how much of it we want to open it up. Now, one thing to say that I am very suspicious of scientists when they are humble, right? As a scientist, I think we should be very scared when people are humble, right? Because you look at physicists, they will say that, look, physics is, physics is a very critical domain. We only know a little bit of the universe. We only know a little bit. Our things are very probabilistic. And we know that's not true. When a physicist make a claim, he claim about the entire reality, right? He makes universal claims, right? And what we want to admit in the footnotes is very interesting, right? So the issue is that I do see that there is a distinction between correlation and causality. I will say that there are three distinctions. One is correlation, other is causality, and the other is complexity. Right? You will say that some statistical techniques will give us an idea about correlation, association. Some physical laws, universal, gives things about causality. That is, something is bringing about something, right? There's a causal relation between everything. My blue shirt and this temperature, right? You can do a statistical study. Is there a correlation between me wearing blue shirt and the temperature? Maybe there is a significant correlation, right? But you think that no, cognitive claims and far more serious. You want to say that something brings about something, then it is complex, causal. Somebody might say that no, the way in which you wearing shirts and you wearing things, not mere correlation, is not mere causality, but it's a very complex system into which they are. So we need to use sophisticated statistical computer science modeling technique to capture that complexity. Now, the issue is that should medical science today want to open itself to its claims to these three domains or more domains which will emerge into this? Or they want to say that, look, after all, it is all correlation. Right? Of course, it's only when you come to me as a patient, I will tell you that if you take this medicine, this will cause the removal of the headache, is only a way of speaking. All that, but our science claim is there is a correlation between this intervention and certain output, right? Of course, we can take that view, right? Then we can ask about, okay, how is this practice going on, right? We'll get a picture of it. Otherwise, by saying that, okay, these correlations are only, and sometimes we, for example, when the 18th century Semmelweis, when he discovered that washing hands, is important for surgeons, doctors, in order to cure the fever, right? There was no mechanical labor. People don't even know why it is, right? But then they went by a correlation. Suppose if the doctor said, no, we will accept it as science only if causal things are discovered, then how many children will die of fever, right? We can't do that. The same way when, later when scurvy was done, they realized that vitamin C pills or fruits will help the sailors, but they didn't know how it is happening. Right? We went by that. But suppose if somebody says that, look, statistical study done on prayer and cure, right? Even if there are statistically relevant thing, we are not going to buy it. Right? The same way, for example, the example with Naveen said about throwing out. Suppose if there is people falling using a parachute. Now, parachute will reduce the speed of my falling and save me. A statistical analysis might say that that's not true. But still, I ever believe that parachute won't slow down. No, physical laws of nature ensures that parachute slow down. Right? Now, why he dies, we should explore it otherwise, right? So there is a connection between correlation and causality. Does the doctors want to worry about it? Is it significant for them to worry about it? Or they will see that we can really practice it, by causal argument. And my personal belief is that I think that doctors just need to claim that this is just correlation, right? We think that medical science works by legitimizing its claim. To legitimize its claim, you have to make some stronger thing to people. If I really say that, look, this medicine and the other one, there is a correlation, people don't buy it. But you will have to say that there is something which is causal, right? So, but I don't think that science work by legitimation at all. See, in the sense of, we practice, I work in a department of non-causal research, right? Social sciences. They don't have any causal research. But social science is very effective in running the society, right? And that is not by legitimizing. People are not asking, oh, we need to give in our project proposal some justification by sociologists. No, sociologists intervene in constructing some basic categories by which people are identifying themselves as individuals, centers of power, democratic citizens, etc. So it has nothing to do with people buying that idea at all, right? So I don't think knowledge works by through legitimation of people believing. That's why you mentioned about reading Foucault, right? Foucault is the one whose thing was that he looked at the kind of medical knowledge which has gone into prison practices, etc. And he realized that they are the third-rate medical knowledge which went into. Nobody cared for them, right? It's not that medical knowledge which is accepted by everybody as scientific thing has effectivity. Very often, third-rate things have, effectivity. Sometimes there are, for example, during the COVID, wearing mask. I have been looking at the statistical evidence and meta-analysis. There was an absolutely, to my mind, convincing claim to say that there is any statistical correlation between wearing mask and avoidance of COVID. But it was simple causal faith that, look, we need Amar Chitrakatha, no? There are viruses, colorful viruses jumping from one person to other person. So I parroted causally an intelligible story to me, right? Even though I know that there is no really non-clinical evidence of that, right? It works. And look at the way things work. For example, the entire non-paramedical intervention during the COVID was based on Neil Ferguson's paper on non-medical interventions. That lockdown basis was that, right? And the paper came out in January, and it was published in a journal only in July. By February, March, lockdown came to effect. It's not that it is reviewed or anything, right? So the major medical intervention works not even before anybody accepted it as one. And it's not that people needed any justification. People would have taken anything. There are countries like, which I will talk about tomorrow, Taiwan, where they didn't have lockdown, right? There was and they didn't also have anything about herd immunity or anything. They used digital technology in an absolutely innovative manner in order to counter this question. And Neil Ferguson, he became the head of the epidemic cell in England. And England has this thing that during lockdown, even partners cannot, if your partner is elsewhere, they can't come back to the residence. And he had a relationship with some other woman. So, but she came to his apartment. right? So he himself didn't believe in it, what he was doing it. And the British tabloid made it into a big issue and he lost his job, right? So it's very tragic the way how some of these things work. And this humility, what I'm saying is, we, at least for this discussion, we should get out of the humility. They say, no, we don't make such strong claims, right? Doesn't have anything to do with you making the strong claims. In fact, see, in fact, Nisar, I think Nisar once said about Vinayam. See, the Sanskrit Malayalam word for humility is Vinaya, right? And Aristotle himself said Vinaya is not a good virtue because humility is lying. If I want to be humble as a good singer, I should be a good singer and I should know that I am a good singer. But everybody else, I will say, oh, no, no, no. I am nobody compared to Yeshudas. Right? It's kind of systematic. It doesn't help us in getting a grasp on it. And Nisar used to say that it is Vishesha Naya. So when all other strategies are failed, then you use a special strategy called Vinaya. Right? And so, at least in this discussion, let us make the best claim because we are not here to defend physics, we are not here to defend medicine, right? But we are simply to explore, open the horizon, how much we want to radically question. See, my class, I asked my students, do you believe in God? They say, no, no, we don't believe in God. But they go to, church or temple, they will only marry people from their own caste, even if they don't believe in caste and all that. So I asked them, then why do you pray? They said, that's only for our mental satisfaction. Right? This is the height of humility that you are saying you are critical, you think that there is not God, but I believe in because, but what we have to say is, no, you are not somebody who is capable of doing the radical action. Right? There are commitments you are thinking, absolutely orthodox commitment you are thinking, which is allowing you to take this radical posture, right? And in cultural studies, there is another, example which people like Zizek has popularized, that Niels Bohr, the great physicist, he has had a horseshoe hanging in front of his house. England has this belief that if you hang a horseshoe, it will drive away evil. So somebody asks, you are the greatest living physicist, but do you believe in all these things? He said, I don't believe in it, but they say it works whether you believe in it or not. Right? So these are the various ways in which we can distance ours from the commitment to some of our belief. That's why Naveen and sort of saying that, look, it's the authority which uses, right? It coexists with our humility. And that is the authority which we need to radically question to see how much we can go. So in that sense, I would, yeah.
Can I add something from a personal experience to that? Because my sister is from cultural studies background and I'm from medical background. In medicine, what I observed is from the time that like after plus two you come to do MBBS, after an entrance exam, then you come to do MBBS, and you are kind of trained to be humble during your MBBS time period, and as well as you're working even. Even when you work, you're trained to be humble. And as you said, it is a lie. It is a truth that it is a lie. But you're trained to be like that. And regarding that provocation or something like that, when me and my sister, when we started these discussions, and she was doing her PhD long time back, I did take it personal. Whatever she said, I did take it personal because I am not trained in arguments. I don't know what argument meant. So when now when I see I argue that, I know that it is not fighting. It is just that I am putting forward the claim and I am trying to say why I say that, and because of these reasons I'm saying that, or these are my reasons for saying that. But for generally a medical person, an argument is a fight. If I tried to make a discussion in my class, once I was doing my residency and something came up regarding the patient's rights, and I was making my argument, and I said I argue because I had heard that word from my sister, and I said my argument is, and they said no fight here. So it wasn't a fight. It just I just wanted to say this is what I think about it, and then it actually turned into a fight. It turned into a personal attack, and I had to go out of the room. So that happened, and what I was trying to say that as doctors we are not trained in critical thinking. We are not trained to question things. We are only trained to be humble and trained to accept things as they are without questioning them. So I think it took me how many years, I don't know, since she started PhD. It was at least 10 years before I came to understand what argument actually means. And that is one shortcoming with medical education. So okay, I just wanted to pass that comment on.
No, I also think that doctors are actually genuinely humble people. On the one hand, their game is with death and suffering, right? Which has given them a certain maturity and humility which no other a physicist or engineer cannot, because for him success is almost guaranteed, right? But for a doctor, and that's what the word critical is so important. The word they use at critical thinking.
Critical is a term which comes from the multiple components. People are in critical situation. As you know, both comes from a Greek word called krinon, the think, critical thinking. It actually means crisis. It means you are meeting a person who is in crisis. Crisis means all the method which I can use to save the person can also kill that person. And doctor is someone who acts in situations of that sort. That way, doctors don't have to take any critical thinking comes from you. Right? Not that you have to learn critical thinking. Right? It actually comes from you. See, that's why I often think that as you're saying it's art or science, a lot of it is far more than science or technology. It's the amazing use of knowledge, and one thing is whether we can appreciate medical profession as something which is more than an application of science, or it's something like a practical activity more closer to science, where you have to act, you know everything. That's why an artist, he knows everything, he's sure about everything. But the thing he has to make has to be absolutely new and unmovable. But it is, you have to be trained, there's a grammar, people have to be trained, etc. Right? So one might say that at least healing practices cannot be worked under medical and science and technology paradigm. It could be something more. And I think as a collection, we should be free to think that. Right? That's why I also thought that we actually have invited three art scholars. We have Riya Solomon, who is a painter, right? And who has been working on the social trauma of India. Like his paintings and his study as everything is on social trauma of India. And we have a poet, Shaju, he has written and he has worked and he has suffered mental disorders. Right? And we have Akhila Vimal, who is a scholar of art and Buddhism, but she has worked on disfigurement. Then how is it that
disfigured bodies appear in classical arts? So they also are people who have actually worked on things like pain, blood, disease, suffering, right? Very seriously. So we have to just take it up whether we have anything to take from them, right? That kind of exploration. Quickly, since we are running out of time, but I think this is what we want to really open up. Another question which we will talk about is the question about alternative medicine, right? So, in some sense, it is, I think today Matulika will start that discussion. We are very lucky that we have something called alternative medicine, because we don't have alternative physics or alternative mathematics, right? So, should we think about this situation as something good so that we can think about medicine more meaningfully, or it is an occasion, the last fight, and kill them? And anyway, they are going to be reality. That reality has something for us to think about. This, how do we understand it holistically, right? But my own experience with traditional medicine, it is so unholistic. In the sense, I don't know whether in Delhi there is this tradition of Triguna Vaidyas. They are Nadi Vaidyas. So the doctor will sit there, the hundreds of patients. Each one will get only less than 2-3 minutes. He will feel the pulse, he will write the medicine. Now, if you have to talk as a person about your suffering, his son is sitting nearby. So while they are taking the medicine, you can convey your suffering, everything to that. Apparently, their teacher, Their teacher, even the face of the patient used to disturb him. So he will sit inside and have a thread outside. The patient has to tie the thread around the wrist. He will feel the pulse only from inside because you don't even want to see this suffering patient, right? So this whole idea that, I mean, some of the, if you look at Hippocrates' treatise, it starts from axiomatic principles. It doesn't talk about patients or anything. Body is a theory of body. From there, you get into disease. This whole idea that tradition means it's a holistic picture is our own fantasy. Modern fantasy is that, our life is individualized, something else called holistic thing elsewhere. Are we bringing that into medicine alternative, or how do we approach this modern medicine? These are things which we don't have, or they are actually involved in a long tradition of healing suffering. These are some of the things which, and I think today our encounter is happening in the front of couple of things. First is we are living in the post-genomic era, right? Our ultimate fantasy was that finally we will find out some gene location which will cause all these things. Right? With genome, I think that has gone up because each functional characteristics has hundreds of locations. Right? We don't know in the, and almost how many percent, 90 or more than percentage of our DNA is just junk DNA. Right? We don't have anything to do with. And they think that that will actually be doing something like epigenetic purpose. We thought that the central dogma of genetics was that nothing will get from gene to the world, but it's only from nothing from the world to gene. Everything will be from gene to world. Now we think that our context actually makes a difference, and those differences are genetically carried over, right? So today, what does it speak about medicine today without that fantasy? And another crucial term which will come into our discussion is the question of biopolitics. I don't know how many of people from cultural studies will be familiar with, right? And the idea about biopolitics is not like medicine is used by political authority or anything, but it is sound from the certain observation about modern power structures. They said the traditional power structure, like the usual sovereign power structure, was always the idea was that we have the power to kill you. We will let you leave, but if you oppose, we will just kill you. Right? And then there was this new form of power thing which is interested in promoting life. Right? Promoting life, and the promotion of life can be extended to killing you. But the power's real operation is encouraging life. Right? And the whole thing about data gathering and the way in which the COVID thing was handled, etc., are a certain way in which the crucial aspect of the biopower is they are interested in the survival. Right? It's the first time the agenda was put to you as the survival of the people. Right? Suddenly, everybody, our only thing is survival. That's what in Delhi. That was the time of anti-CAA protests, right? And I was a member of some of the right-wing WhatsApp groups. So the news where there was, please put a COVID patient there, the CAA protest will be over. And it was over. Right? The entire major protect of this thing was, they said, what politics? You have to be alive if you want to fight politics. Right? But on the other hand, we had farmers' revolution, the protest taking place. I've been there a couple of days. There was absolutely no COVID protocol inside. I was just wearing a mask. When I went in and I found out really healthy Sardarjis without mask, I felt so ashamed as I put the thing into it. And they have a medical care. There were doctors from AIMS there. They will attend to people. But they refuse to have a politics where survival values more than questions about political questions, right? And they had a thing about people taking turns to go to the village, get vaccination, etc. But they just refuse to have a politics. And I think today we don't attend to that. There was such an organized political movement which, as part of countering the state, they said we will not refuse the politics of survival. And but what we call biopolitics is something which actually the politics of survival, and it's also a politics of suffering. The whole idea is that you just want to make the other person suffer. Right? For example, if you look at the Gaza war, you can see that they are not trying to win anybody or trying to get Israel wants, they can get that area. The idea is meticulous practices of suffering, right? That is a pure value in itself, right? And earlier wars were wars done under, the just war thing about there are rights you do in order for self-defense or conquer things like that. Now there are no such that's why we are all worried about how can humanity allow such violation in Gaza. But that's the precise logic of the Israeli military tactics. They just want pure suffering there, right? So there is a new medicine. It's not a medicine is used, but medicine is practiced in a certain deployment of power like that. And that is whether you have the traditional sovereignty, which is based on obedience, right? Then you have what they call the power based on discipline. People want you to have rights, right? Once you have rights, you can, so you recognize your rights, then you accept some responsibilities, then you are free to do anything you want, right? That's the idea of a discipline. But people say the new power is neither a power of obedience nor a power of discipline. It's a power of survival. Some people call it molecular power because what you're saying is it's no longer addressing you as a citizen or a subject citizen, but it's like only a genetic structure, certain molecular DNA mapping. These things really count for you. It's like if you want to get a citizenship of Israel, I think now you have to produce your DNA map. You can't just go there and say we are Jews and all that. And the real culmination of this kind of biopolitics, the central thing was people analyzed it in terms of the Nazi camp, right? In the Nazi, racism was an attempt to improve the life. We often think that Hitler was interested in supporting the Germans. That's not the case. When the war was, Germany was losing, when Hitler came out, there's a very famous telegram 71. Hitler telegrammed by saying that, look, the nation is lost, right? Now he wants every German, almost if he had a chance, to commit suicide. The idea is that it is to improve the life of German. For that, you have to kill Jews. But if that cannot be done, the entire nation should go, right? Because that is better for this betterment idea. So apparently Nazis have plans that if eventuality, they will poison all the wells in Germany, right? You will kill people. Because the idea is now there is nothing against, we are against somebody or anything. It's life and the things about corruption, right? But this idea biopolitics has come into a lot of criticism after, because people believed it as if all these states are using medical powers, medical data in order to control people. That was not the case. The control idea is all gone now when people try to analyze something in terms of biopolitics. So as one of the digital thinkers called Benjamin Bratton, people are confusing Auschwitz with airport security. Right? People think that if you want to say airport security, this is the same thing which led to Auschwitz. So another thing is this idea about survival, suffering, and then security. Right? Today, everybody wants to live in gated community homes, and in IIT, our classrooms are also now under CCTV cameras. Right? Now the thing is, there is a life form which is developed about it. Right? Whether you want to get into those, protesting now against this is the idea about complexity. That is, you are now caught in a complex thing, whether your individual oppression, your individual feeling as not thing. What is needed is certain abstract data, which there are engines to take it from you, right? And that makes you into a political subject. The thing about your protest, everything, whether you don't want to have a surveillance camera in your home is just personal, emotional things. And medical practice is also going to be done within this power structure. Right? So now what are is it advisable thing? That's where somebody like Foucault, who came up with this concept, finally he said, the real challenge is how do we now pursue techniques of fostering life and also of death without falling into this, right? We want to learn how to die, not by caught by this molecular biopolitical machine, right? Now that's what the suicide also has become a matter. Somebody talked about it, death, statistics, and the moment somebody commits suicide. In IIT, it's like this. We have Dalit students committing suicide. So Dalit student is already into a data of incompetent people. And when he commits suicide, he has a mental illness. So he is doubly caught in the day. Like we are a society where you can't think about suicide as a choice. Some people might just choose and things. So there was a time when we have guidelines how to commit suicide and spiritual help and possible. But today we are not, right? But this is important things to which we can actually think about. And let's just to name things. One is another topic we should perhaps discuss is open up this question of pain. How do we understand pain? How much of pain can be a subject matter of an objective science? And what is it that objective science attend to about questions of pain? What is pain? Right. So when do you think that, not see in Indian tradition, many traditions, we say Vedana means any sensation is pain, right? So we think that sensations, but somebody touches me is not pain, but it crosses a threshold, then it becomes pain. Many of the gateway theories on pain and all that, trying to model this. When is it that a sensation crosses a pain? That depends on a strange idea about what pain is. Right? And that when I say I have a headache, it's not in the sense in which I say I have a car, right? Because I have a car could be, maybe it's my fantasy, I'm telling you a lie. You will go and find out I don't have a car, but I go around saying this. But when I have a headache, if you tell me that you really don't have a headache, it's all in your mind, I will think that you're insensitive. Nor will I ever get mistaken about my pain, that I have a headache. I will say, oh, I thought I had a headache. Actually, I had a toothache, right? We won't say this. So in that sense, there is a non-representational immediacy to pain. But at the same time, we know that pain is socially constructed, and there are traditions of art forms. So that is, we have a performance artist talking to us about it. There are people actually create pain, right? And representations of pain also has a problem. We were talking yesterday that when Darwin tried to write his book on, you know, emotions, like he need evidence. That is the time photography comes in. So he has photography now. But then the problem is that emotions change so fast that the photography cannot capture. So he used flips on people, like when sadness, which are the muscles trained. So keep it like that and take the, photograph, right? So it's also what is the kind of evidence. So in fact, we had the discussion about evidence. The real question is, when does something prop up as an evidence? For example, autopsy was not accepted by medical practice. Our today story is that church was against autopsy, so we won't allow it. But that's not the case. Dead bodies were available all around. But doctors never thought that a dead body can produce any evidence for a living being, right? So that's where that beautiful sentence from Foucault says, at some point in 16th century, they found the light of death can illuminate the dark interiors of the living body. See, that's the time it becomes, for example, something like a cough from an illness becoming a symptom, right? So what are the conditions under which something is constituted as an evidence? So pain itself is it an evidence? So you have something called pain. An Indian tradition, some Indian tradition actually says, what is pain? Pain is a place where, see, weight comes from the dhatu, with, right? Vedana comes from with. Now, with actually means knowledge, jnana. It also means akhyana, narration, or throwing light. It could also means a place where I am rested. Now, Vedana, na is negating. It says it is an experience which doesn't involve knowledge, which doesn't involve narration or light, which doesn't involve rest. Right? It is that kind of a strange experience. So it's not seen as continuation of a gradation of sensation. It's not like I am pressing at some point, something triggered, right? So do we really need, when you have various now illness related, myalgias, and then there are, almost pain itself is causing pain. You have things like chronic pain. So what kind of an abstraction is that you? So you have sensation, then you have pain, then you have suffering, right? It's not like this is something which people discovered, that not all pain people don't want. People really want pain, right? And doctors noticed this about art. Their criticism of 18th century art was that the paintings of painful faces are beautiful, right? We look into it, right? So something about pain is violated by anybody who try to represent it. That's, we say that about everything. For example, there was a ban in Hollywood about showing films on 9/11, right? Because they think that if you really show that 9/11 bombing, then it falsifies the experience of trauma. So you shouldn't represent it, right? So what is the nature in which pain will become something which is representable, right? So you have sensation, you have pain, then you have suffering, then you have things like trauma, right? Trauma is like big things like, the wars, like partition is a big trauma, right? What are the conditions for something to become a trauma? Right? So some people are saying that now Alzheimer's disease is not a disease, it's actually a trauma, right? It is something where somebody has become somebody else, right? It's not like my memory has gone down, right? It's not the same person. When I look at one of my aunt who has Alzheimer's, I know it's a different person. I am dealing with a different person. That person has minimal consistency to work as a self, but it's not me. No, it's not very strange. For example, another traumatic experience is experience of humiliation. Suppose we are humiliated somewhere, not merely ashamed, but humiliated. What is my memory? How could I be? Right? I am saying that, look, this me who is talking to you cannot be the person who is being laughed at in that crowd. Right? I have a self-distancing in it. I am living the life of that person who was humiliated, but I am not me. Right? So what is in brain? If what is it about our brain that which will allow a sensation to become pain, a pain to become uh, suffering, a suffering to become trauma, right? I think what kind of a preparation you need, merely by saying that it is some nerve is stitching there, doesn't track these conceptually rich things which we go through. But ultimately, you have to understand, have a theory of brain, right? After all, it is brain which is, it's just people with this brain structure that we have all these domain, right? We don't even know whether animals suffer. Animals may have pain, but we don't know whether animals suffer, whether animals feel humiliated, they feel traumatic. We don't know. Definitely, we know it has something to do with brain. So people who work on my people, so if some people, students who work on Dalit studies, I thought you have to do a course in neurobiology, because ultimately you have to really understand. You cannot come up with a social narrative if you really want to address somebody who is experiencing this. But then, as you know, neurobiology, you think that this is all like some neuron firings again, but these neuron firings are plugged into conceptually rich life forms, right? They have to get, that's why people call it plasticity of the brain, that the brain actually can change according to its experiences, right? Does anything in our vocabulary, can we open our neurobiological theory to understand something like this, to understand somebody who is undergoing this effort? And another topic will be psychiatry. I think we won't go into it. The people, we have Robin here, right? Psychiatry is one domain where there has been some fruitful move from the side of psychiatrists towards social sciences. Like, in fact, many of us have some interaction with AIMS and the Kerala, the Psychiatric Association. There is a feeling among them that, look, the medicine works, but they don't understand how it works. Right? That's a nice way for a scientist to do it, not by questioning him. It works, but I don't understand what I am uh, doing. They are not saying that, look, our therapy is not effective. We want somebody to make it more effective. They know it works, but they don't know the nature of that interaction, right? So then there are other standpoints, like people like Rubin will tell us, which says that no, we already have a certain familiarity with ourselves, right? And these delusions are not I am being fooled, but these are experience of a self who has a very deep knowledge of itself, right? Whether that knowledge can be tapped by medical knowledge, or they will say that we can only do what everybody else can share, but can we actually and you know that literary studies, social sciences are very good in this, to access the way in which the world is disclosed to people in a unique manner. See, there's a certain unique manner in which this room appears to me, which is not like anybody else. But there's no mystery to it. I can easily understand you as somebody who does this, right? And I can respond to your most innermost feelings, innermost pain. And there is a cognitive basis, is not neuro. I don't expect that the other person's brain map to find out whether the other person is in pain or anything. Right? I can talk to it. In fact, this is the worst in our interaction with machines. Like whether computers can think or feel, we have a big problem understanding. And we devise logically complex Turing test and all that. But what does the computer do? Computer is also sometimes doubtful when you search databases whether you are human. They just ask you to check a captcha, right? Then the computer is happy to recognize you as a human. No, this is exactly the way in which I recognize you, right? I didn't ask any of you, you should file a DNA or genetic test to come here. We take it for ourselves and we are not mistaken about it, right? So the scientific inquiry into human mind and psychiatric diseases should count on this knowledge. And we have to think about social sciences and humanities have devised pretty rigorous protocols to access this, narrativize it, communicate it in manner. Now, whether it could be possible that these are entirely two different worlds and they cannot meet. But I think we should make an effort to meet. And perhaps the last one, which, and again, as alternative sciences, I want to say that what is very lucky about psychiatry is that there is something called anti-psychiatry, right? And psychiatrists could accept most things which anti-psychiatry. Anti-psychiatry is a thing to say about the privilege of the doctor in the field, that the clinic has a privileged location for madmen to speak, right? But we know that psychology is not to tell the truth about madness, but madness hold the truth about the psychologist, right? It's not the other way around. So they wanted a certain interaction where the doctors don't set the agenda for this conversation, which I think is increasingly medicine is moving towards that, but whether that route is right or wrong, right? So in that sense, there was a productive dialogue between psychiatry and anti-psychiatry, and they could institutionalize a lot of these criticisms into their practice. That's something which we can actually think about. People who are critics need not be trying to shake it, but a lot of things could be included into this practice. That's, for example, that's the way things like physics works. For example, there was a radical critique of mechanical causality in physics, and they absorbed it and they revised their notion of causality, right? Today, quantum physics can work with fairly sophisticated notion of causality. So I'm sure it might be medical science might also be able to do that. And the last topic which we can discuss is this question about care, right? How do we think about uh, care, and what is this? What are the steps? We immediately we say that doctors all have to be caring and compassionate to people, but we have no clue about what is the knowledge basis of care. What kind of a knowledge is that? Is it that we have this knowledge and we have to just make it human, or the caring people, the nurses, paramedical staff, they are facing a reality which we cannot comprehend, right? That's why people who worked with traumatic situations like in, the death camps noticed a sheer inhumanity in the eyes of the victim. Their suffering can bring you down to a level which is below humanity, right? Where the person who dearly asking for care doesn't express any need, right? We think that caring means giving the patient what he really needs, right? So that's why caring doesn't have a universal protocol. Like we can't say like medicine or technology, this ought to be done. We have to attend to the specific case. Then we think that the specific case, the patient will tell me what I need, water or wind or whatever it is. But what if the carer is actually noticing something which is terribly inhuman, totally dead in the eyes, and the real caring is encounter with that, not like compassion, other people, identify other people and all that, nor it wants to come from our humility. Look, we don't know everything, so we have to be humane, something like that. But caring people are, and I think a lot of work in literature, in visual arts and cinema studies have now brought about this, that, aspect of this. Now, how much of our caring discourse, right, want to really encounter in theorizing it? I think these are some of the issues I thought that we could take up with me, and others are also welcome. You can say as part of your